I'm Dr. Lawrence Robbins. I've had a headache center a little north of Chicago. Well, I'm a dinosaur for more years than I care to admit. Actually, 32 this is our 32nd year. And a lot of the references I'll make today or the information is on a website where we've published maybe 25 articles. That website, it's a free open access, and they have a for patients too, but our articles are all there. It's practicalpainmanagement.com, and our website, Chicago Headache Clinic, has a lot of information. So when we're talking about refractory, we talk about difficult to treat. Refractory isn't that much different than difficult to treat headaches. And refractory chronic migraine is basically frequent migraines, chronic migraine, at least 15 days a month of a headache that bothers people. And when we talk about refractory, I started the section of the Headache Society called the Refractory Headaches section many moons ago. And when we talk about refractory, we mostly talk about where the preventives have not worked. There are different subsets of refractory. There's adolescents, there's refractory patients in their 80s, and age is very crucial. We treat 15-year-olds with difficult headaches a lot different than 40-year-olds and much different than 70-year-olds. And we actually have the old, 70 or 75, and then the very old, 85, 90, 95, and they're different. There's a lot of challenges besides defining refractory migraine. Migraines can change, refractoriness can change. So somebody might have a different season where they're much better, a different year, go off and on in cycles. So it's not a static thing. Medication overuse headache is very important. And I want to digress a little bit to talk about medication overuse headache. I just published an article on this, and it's on that site that I mentioned, Practical Pain Management. I think it's also on our website. But medication overuse headache is fraught with confusion. I think that it's overdiagnosed and it's fairly poorly defined. It's not so easy to tell if somebody has medication overuse headache. People are reflexively told, well, you're using too much, Excedrin. Whatever they come in on, they're told you're taking too much Buranol or opioids or Excedrin or triptans or Advil or Aleve, whatever you're taking, and that's giving you headaches. But it's much more complicated than that. People need to take a very careful history and see, did the medicine actually accelerate headaches? And what happened when you withdraw the medicine? Did it get better? And then treating medication overuse headache is not easy, taking people off of the only thing that might be helping. So what I call the second half of the sentence is not answered very often. People say, well, I'm on Excedrin for a day or Furanol, and the doc says, well, you can't take that, you're getting medication overuse headache. And people say, that's fine, I don't get high off the medicine, I don't need the medicine, but it stops my headache. What do I take? And the second half of that sentence, which is what do I take, is not always answered. And the problem is our preventives, even including Botox, don't work for maybe 45, 50% of people. I've done a couple of studies long-term where over a year, the last 6 months of the year, the preventives stop working or people have side effects. So what do the other half of millions of people with frequent headaches do? And that leads to the refractory. Now, a few years ago, I published an article on a refractory scale where we looked at mild, moderate, and severe refractoriness. And we approached people differently. So you take severe, somebody is 50 years old, they've had 35 years of daily headache where nothing's worked. They have a lot of psychological conditions, medical conditions, other conditions that are related to headaches like fibromyalgia, chronic pelvic pain, irritable bowel syndrome, and it's been decades where nothing's worked. That's more severe refractory. You take the milder refractory, a 21-year-old who's had 9 months of headache and the preventives haven't worked, but he doesn't have much else going on that's complicating things. That's a mild refractory. And of course, we're going to have more success, particularly outpatient, with the milder refractory. So I think separating out also how they came about. New onset daily persistent headache, NDPH, happens where people start having headaches over 24, 48 hours. They may have a viral infection, they might have a surgery or a stress, or a traumatic brain injury. People can have be rear-ended, they can be tackled on the football field and start having daily headaches. Those are tougher. New onset daily headache or traumatic brain injury is tougher than transformed migraine, where people have more and more headaches. They start out at age 12 and they're getting 1 headache a month. Then they have 5 headaches a month by age 18. And then by age 25, they're having 25 to 30 headaches a month. The transformed migraine like that is usually easier to treat. When people have migraine components to their headache, which is usually, it's easier to treat than just chronic daily headache, where people just have daily headaches. So we're always looking at what can work outside of medicine. We want to minimize medicine. We want to balance headaches and medication and not over-medicate. I usually say it takes a village to raise a headache person or a severe pain patient, and we get other villagers involved. So what are other villagers? Well, physical therapy is very common, particularly if people have posterior headaches in the back of their head. Half the people with headaches have neck pain. So we'll send people to a specialist in headache physical therapy or physical therapy person who has an interest in headaches, and they'll work on posture and stretching and what to do on the computer and that sort of thing. Psychotherapy is very common as a referral. A lot of people have anxiety or depression. We don't refer to psychotherapy with the hope that it will cure people's headaches, but it helps other issues. Sometimes I say if it was up to me, everybody in our society would see a psychotherapist. But because of money and time, people often don't go. And then we use a variety of other modalities, massage, sometimes acupuncture, biofeedback, meditation, and there's some good meditation apps like Calm, and Headspace is a decent app, yoga. We're always pushing exercise, trying to get people to do 20 minutes a day on average of exercise, even 5 minutes at a time is worth it. The old mantra that you have to go to the club and get your heart rate up for an hour, otherwise it's not worth it, is not true. New York Times actually has had a number of good articles about 1 minute, 5 minutes, 10 minutes of exercise. So we're trying to get it. I like stationary bikes, get it into people's lives, exercise easily. I like the bike in front of the TV where you can fit a laptop on with a headset and listen to podcasts, et cetera, et cetera. So we're always trying whatever we can outside of medicine that might help. A couple other non-medicine aspects. Catastrophizing is very important. If you look at disability, who's disabled? The people who catastrophize, go 0 to 60, come in and say, these are the worst headaches in the world. Nobody's ever had headaches as bad as I've had. Has anybody ever had headaches like this? And sometimes we get from moms or dads about their 16-year-old what we call catastrophizing by proxy or by a spouse. Oh my gosh, has any 16-year-old ever had daily headaches like my daughter does? This is the worst thing in the world. Her life is over. That's catastrophizing. So we try to dial that catastrophizing dial down a bit. Resilience is a very important construct, and it's very complicated. You could study resilience for a month, 24/7. But we're trying to improve resilience. There's a very genetic component to resilience. If people have 2 long arms of the serotonin transporter gene, 2 long arms of that gene are good, 2 short arms are not good. So if people had abuse as a kid, sexual, physical, emotional abuse, it often leads to severe pain, fibromyalgia, and sometimes depression and anxiety, but headaches as an adult, because abuse as a kid really affects the developing sensitive serotonin pathways in the brain. And you can predict who may be resilient based on this serotonin gene. There's a great article in that, by the way, that's still up on the NewYorkTimes.com website it's about 7 years ago, called A Question of Resilience. And it's fascinating stuff. We also talk about acceptance. The road to acceptance is littered with many stops at various clinics looking for the cure. Acceptance means that I have a chronic illness, there's no easy cure, but I'm going to work on it. It doesn't mean resignation. It doesn't mean, well, I have these daily headaches and there's nothing to do. There's always things to do and get them better, but it means that there's no easy cure. So we try to improve acceptance, and we always try to improve coping and functioning. There are low functioners and copers, there's high functioners and copers. A lot of it depends on the first 15 years of modeling at home, genetics, and a lot of other factors. I want to give a shout out to caretakers, because the spouse of somebody with severe pain, the mother, the dad of somebody with severe pain, or sometimes the daughter or son of somebody with severe pain, it's not easy. And the person in pain, it's not easy, but also the caretaker. So we do pay attention to them. Occasionally there are groups for caretakers or for spouses that are very useful. So now I want to turn to outpatient therapy, what we might do, and then we'll open it up hopefully for questions. There's a lot of outpatient options, but where we go with one person versus another, where's the top 10 list of one person versus the top 10 list of medicines or treatments for another person? And there's no good algorithm. Everybody is different. Recently, I wrote an article that's on those sites called Deconstructing the Art of Headache Medicine. And we break it down into 50 parts or so. And some of those parts are the headache history, of course, how many severe headaches, how frequent, the age of the person. As I mentioned, we treat 15-year-olds differently than 50-year-olds. We look at family history and family history response to medicine. If mom had a terrible response to Topamax, we may very well not use Topamax. If mom had a great response to Topamax, we may have, it's genetic, but also the placebo by proxy response I talk about. The daughter may have a good response. So family history is very important. We look at the job requirements. If somebody has to work early in the morning, get up at 6 and think, we don't want to use a sedating drug like amitriptyline at night or tizanidine to make them tired. There's a lot of things that go into this. The GI system, do people have irritable bowel or diarrhea or constipation? If people have diarrhea, it's always easier to treat than constipation is tougher. A lot of our medicines cause that. Weight gain is a big issue. We don't want to give somebody where weight is an issue medicine that causes weight gain. Occasionally it's the opposite, where people are thin and can't keep weight on, so we don't want to use topiramate, for instance, or stimulants to cause that problem. Insomnia and their sleeping is very important. So we always want to minimize medicine and these, what we call comorbidities, other things going on with a person, drive where we go with the medicine. Also, the psychological comorbidities, they have anxiety or depression or mild bipolar. Mild end of the bipolar spectrum is very common and it's missed. And of course, medical comorbidities, high blood pressure, do they have diabetes, etc. So we look at all of these things, and in the end, we use our gestalt, and this top 10 list for this person is much different than the next person. So now I'm going to go into some of the actual treatments. And some of them I'm sure that you've had before. Some of these are off-label. I'm going to first talk about Botox a little bit. Botox is one of the only things that is on-label or FDA indicated for chronic migraine. But I started using Botox about 22 years ago for headaches. We do it almost every day. It turns out very safe. I like drugs that have been around for a quarter of a century. Triptans have, Botox has, because I always say use new drugs a lot while they're still safe. We don't know when a drug just comes out for 6 months and tests have been done in 3,000 patients, but all of a sudden 3 million people are going to have it. So Botox turns out to be very safe, remarkably safe. Probably our best preventive. And it works in about 63% of people versus most preventives work in about 30% at most. And the FDA indication is 155 units all around the head, 31 shots around the head. But you don't always need that many shots. A lot of times we'll chase the pain, just do it on that side. do a limited amount. Money comes in, financial aspects come into treating headaches. If people can't afford a therapy, we'll just do other things. Botox used to be easy to get from Blue Cross and certain insurances. Now it's not so easy. The pre-auth process doesn't always work. But Botox has been very good, and it often helps for 2 to 3 months. So people get it every 2 months, every 3 months, 3 months on average, sometimes every 4 or 5 months. Another treatment is polypharmacy, which we call rational polypharmacy, not just throwing drugs at people random willy-nilly, but fitting their comorbidities. We might use 2 preventives, or we might do Botox with topiramate or Botox with Depakote, or a heart medicine that might help. Most of the blood pressure medicines help headaches. Medical cannabis is another possibility, and we've prescribed it a fair amount of times, but most of the people that I've prescribed it to are self-selected. They said, this has really worked for me. They don't overuse it. We've had no overuse, but it gets complicated. There's different oils. The main 3 are CBD oil, which doesn't have any THC, and then the THC of sativa versus indica. Sativa is more activating, indica is more sedating at night, but it can go the opposite way too. People have different reactions to these. If you do try it, my advice is to try a very low dose. Always go very low. So if people have a gummy bear, take a quarter to start and then go up to a half. 1 is often too much. The newer strains are too strong for a lot of people. Medical cannabis can help. There are some long-term side effects possible, memory, and we don't want to give adolescents, which is defined as almost up to age 22, 23. The white matter of your brain is still developing. It can interfere with adolescents with thinking, with memory, and emotionally too. It's funny, there was just a study yesterday that came out and it said, the headline was, drinking alcohol and smoking marijuana is not great for adolescents. And I was laughing, do they really need a study for that? But it really isn't. The only real long-term side effects that I worry about, medical cannabis or cannabis, marijuana does affect the very sensitive memory centers in the hippocampus, sometimes the amygdala. So you can find different studies on this, but generally it's relatively safe. SPG blocks are another thing where we put Novocaine or Marcaine into the nose with a device. And there's 3 devices out that are fairly expensive, but now we found a newer way to do it that's fairly inexpensive. And that can help for a few days if people go home with some and do some every other day or every 3rd day, the SPG block. SPG means the center, the nerve center right off the nose, and you squirt it up and it filters into that. So for pain in the front, we'll do SPG blocks. For pain in the back, we might do occipital nerve blocks with a needle. It hurts. It's mostly Marcaine or lidocaine type medicine, and sometimes corticosteroids like Depomedrol. And sometimes we'll do injections lower down, trigger point injections in the neck, mostly with the Marcaine or lidocaine type medicine. Frequent triptans, sometimes we don't prescribe them this way, say take Naratriptan, which is longer acting, or Frova, or Sumatriptan, but people lapse into that. And if we're reasonably sure that people are not having medication overuse headache, there are a lot of people out there in not just the United States, but in the rest of the world. Triptans have been around for 25 years, and they've been given to about 300 million patients. There are a lot of people who are on frequent triptans, either 4 days a week or 7 days a week. They're relatively safe. As time goes on, triptans have looked safer and safer. So we don't want to jump into frequent triptans, but sometimes if they're the only thing that works and people function, people always say, I have my 3 kids and I have to work. And what do I do? If you say only take something twice a week and I have headaches 7 days a week, what do I do? Another possibility is opioids. Now, opioids are very politically incorrect to talk about, but there is a slice of patients where they're the only things that work. I've done a number of studies on this, and I did a study from 95 to 2005 and then 2005 to 2015. And over time, our success rate was much more because my patient selection got better. So if people follow if they fit certain criterion, opioids can actually help in low doses. The idea is to stay on low doses. But the criterion are we don't want to use them in young people and sensitize the brain. So under age 28 is not great. We don't want to use them in personality disorders, particularly borderline antisocial personality disorder. We want to avoid if they've had addiction to certain things or if they've overused the painkiller. We don't want to use, the key is if they become tolerant to the analgesic effects. And what does that mean? That means where they need more and more and more. And at least half the people do, and they're not a great candidate. We can't use more than low doses. So if people have become tolerant, we have to find something else to use. But sometimes opioids are fairly effective. Stimulants are underused, I think, such as mixed amphetamine salts, which is Adderall, or methylphenidate, Ritalin. Vyvanse is a newer stimulant. If people have ADHD as a comorbidity. But sometimes people have weight issues, tiredness is the biggest comorbidity, the biggest problem that people with headaches have. There's been a couple studies on this. What bothers you more than the headaches? And it's tiredness. Sometimes stimulants help, but they can also help the pain. There are people where stimulants really help pain and the headaches. So in low doses, they can be helpful. We do use a smattering of a lot of other drugs like memantine, which is used for mild cognitive impairment or pre-Alzheimer's or early Alzheimer's. There's this drug called low-dose naltrexone or naloxone, which you have to get compounded. There's a good website, lowdosenaltrexone.org, and it's a very tiny dose of naloxone, which is used in much higher doses to get people off of painkillers. Low doses, it can help fibromyalgia and headaches sometimes. Sometimes we use muscle relaxants. Neurostimulation has come a long way. There's a TMS device, which is transcranial magnetic stimulation, where it's a big device that they put on the back of your head twice a day or so with pulses. It's actually really quite safe. And recently, VNS, which is vagal nerve stimulation, which is in the front. People have a stimulator. Now, both of these are fairly expensive, but this VNS, people stimulate the front, the vagal nerve, and it's a brilliant device because they have the invasive VNS where they implant something. This, you don't need it, and it's actually quite safe. It just got a migraine indication, but these are expensive treatments. You have it at home, though. There's also neurostimulation where they implant a stimulator under the skin. I've never been a great fan of that. Occasionally neurostimulation is okay, but there's problems. Many patients get complications or need resurgery. We try to avoid it. Ketamine in our office, I don't do it very much anymore, but we did ketamine nasal spray for a while with some patients, and it's very good for depression. They're working on a ketamine nasal spray for depression that'll be commercially available, and you've probably heard or seen in your area ketamine clinics pop up intravenous for refractory depression, but it can help pain. I think it's better for depression than for pain and headaches. Ketamine is an interesting drug, but not to be taken lightly. There's also the ATI stimulator that is a stimulator that's implanted in the SPG, and then there's an outside clicker or stimulator, so there's no leads and wires, but it's a big operation. There are people can get very bruised and have side effects, but that stimulator will probably come out for cluster headaches. There's migraine surgery, which I'm not a big fan of, particularly in the front. I don't like it, and I think the results haven't been terrific, but it's called decompression surgery, where if somebody has tenderness and pain just around the occipital nerve in the back, and nothing's worked. Sometimes specialized surgeons, and there's not that many in the country, are very good. There's a few centers. They will do, it's a long operation, but they will move the nerve away from tissue, and that can help.